Hello guys and welcome back to Counter 10. My name is Arnie and on today's episode we're going to be starting off our new series looking at gastrointestinal physiology. Our first topic today is liver physiology, and I know it's been a little while since my last episode, but I hope that you can excuse me. I've been on paternity leave for the last 4 weeks. Safe to say life has been a little bit hectic trying to adjust to having 2 kids, but I know life's been hectic for you guys as well, given that the exam results were released in the last month. I want to say a big shout out to Robbie, who came on to do a live practice fiber demonstration. He absolutely smashed the exam and ended up getting the Renton for this sitting. Me and him have been chatting post that, and he's going to come back on the podcast after we finish this series to go through a series together where we look at inhalation anesthetics. A topic I truly believe is really hard to grasp, and even now I find it really hard trying to find really good study material for that topic. But that's all in the future, and for today's episode, we're going to be focusing on liver physiology. And when it comes to liver physiology, really there's 3 aspects to this. The first is understanding some basic function. The second is understanding the blood flow and its significance. And then the third part is understanding the laboratory investigations we can use to examine liver function and how that plays into pathological states. So that's basically what we're going to be covering today. And with that said, let's dive straight into it.
1, 2, 3, 4.
The first learning objective today is outline the functions of the liver. And before we talk about the specific functions, you guys know that I love to talk about anatomy to help you better understand what the functions of the liver are. When it comes to anatomy of the liver, the basic things you should know is that the liver is the largest visceral organ, roughly 1.5 kilos in a healthy adult. It can be divided into its macroscopic and microscopic anatomy. When it comes to macroscopic anatomy, this is more important when we talk about the surgery aspect. The macroscopic anatomy divides the liver up into 8 segments, and these segments exist because they each have their own portal vein, hepatic artery, and bile duct supply. And what that means is you can remove one of these segments without altering the function of the remaining liver. So it's really important for the surgeon to know when they're doing their resection. From our physiological perspective, what's important to know is the microscopic anatomy. And when it comes to the microscopic anatomy, you can look at the liver and divide it into 2 types of units. You have the histological unit, which is referred to as the hepatic lobule, and then you have the acinus, which is the functional unit of the liver. With regards to the hepatic lobule, this is characterized with the central vein being at the center of the hepatic lobule, compared to the acinus, where the portal triad is at the center of this functional unit. And when we talk about portal triad here, because we're looking at this at a microscopic level, the portal triad here is the hepatic arteriole, the portal venule, and a small bile duct. Why we divide the liver microscopically into these 2 units is because they have differing roles. The histological unit, being the hepatic lobule, mainly has a role like an endocrine function of the liver, while the acinus, the functional unit, has more of a role as the metabolic hub of the liver itself. And this is the one people like to concentrate more on. You can further divide the sections of the acinus into 3 different zones characterized by proximity to the portal triad, with zone 1 being the closest, zone 2 being intermediate, and zone 3 located near the central veins. The reason I explain this is because this has a relevance to clinical implication. Zone 1 receives blood flow first and has the highest O2 content. Here you see high metabolic rates and high activity such as protein synthesis. So if you ingest a drug or a poison, this is the part of the acinus which is going to be exposed to it first, leaving it the most vulnerable to injury from drugs and poisons. While zone 3 receives the lowest amount of oxygen but has a really high concentration of the P450 system here. So if the liver suffers hypoxic damage, this is the zone that's going to be affected most, and clinically you'll see here alterations in drug pharmacokinetics due to the P450 system being affected. And that's why knowing these zones is important, because it has clinical effect. The other important anatomy aspects is understanding what type of cells make up the liver. By far the most common cell in the liver is the hepatocyte. This contributes 60% of cell mass within the liver and approximately 80% of the liver volume. It has multiple roles which we'll talk about later, and this is due to the fact it has a variety of organelles stored within the hepatocyte. But importantly, these cells have a huge amount of mitochondria in them because they're a hub for so many different activities. The other type of cells that are unique to the liver are the Kupffer cells. These function as the macrophages within the liver, and they circulate near the sinusoids, which are the low pressure microcirculatory system of the acinus. They have a key role in bacteriophagocytosis, protein denaturation, and interestingly enough, in neonates have a hemopoietic function in the first 2 weeks of life. Then you have the endothelial cells, which have a unique property in the liver because they have large fenestrations. And if you ask yourself, why do you have large fenestrations? Well, it's because the liver is going to produce large things like proteins, and proteins need to be able to get out of cells and into cells. So therefore, the endothelial cells need to have fenestrations to allow that transfer to occur. And because that exchange probably isn't going to be quick, you want that circulatory system to be really slow and therefore a low pressure system, so there's as much time for exchange to occur of these large substances. Finally, the other unique cells in the liver are the Ito and Pitt cells, and these are kind of considered the natural killer cells within the liver itself, but they also have some additional roles in deposition of collagen, which can lead to fibrosis and potentially cirrhosis later on. So that's a really broad and basic overview of kind of the functional anatomy of the liver, which allows us to then go in and better understand the functions of the liver. With regards to the functions, there are so many functions of the liver, and when I was trying to go through this, I tried to make an acronym to help me remember all of the functions. But it's not so much knowing lots of details about all and each function, it's more so knowing a broad amount of knowledge so you can list as many points as possible when it comes to an SAQ on this topic. The acronym that I made, which isn't very good, is MIST-HH, and this stood for metabolism, immune, storage, synthesis, excretion, detoxification, and then the two H's were hormonal and hematological. So those 8 functions are what we're going to go through now broadly in this next section. When it comes to metabolic function, there are 3 different types of metabolic function that the liver is indicated in, and these 3 are carbohydrate metabolism, lipid metabolism, and protein metabolism. When it comes to carbohydrates, think of the liver as a glucostat, maintaining the blood glucose level within the normal limits. And this term glucostat, examiners love to hear as a buzzword when it comes to a Viva time or an SAQ. How the liver actually works as a glucostat is in a couple of different ways. If the BSL is low, it can increase glucose through the effects of increased glucagon and decreased insulin via either stimulating glycogenolysis or gluconeogenesis. And if the sugar is too high, it can either bring it down through the effects of increased insulin and decreased glucagon via either increasing glycogen synthesis or glycolysis. Now, to better understand this, we have to quickly review basic first or second year med school by understanding how carbohydrates are broken down. For this process to occur, they're first broken down to either disaccharides or monosaccharides in the intestinal mucosa, and then these sugars are taken up by the portal vein, delivered directly to the liver, where glucose enters the cell via GLUT2 receptors, which are insulin-independent transporters. Once the glucose enters the cell, it's quickly converted into glucose 6-phosphate by an enzyme called glucokinase, and this step is really important because it maintains the glucose gradient so that glucose keeps coming into the cell. What happens to all the dietary glucose that we consume? Well, 10% gets made into glycogen, 40% gets converted into triglycerides, and 50% goes through glycolysis. Remembering from basic sciences that glycolysis has 2 steps. The first step is the production of pyruvate, and the second step, in the presence of oxygen, is going through the citric acid cycle and oxidative phosphorylation to end up making 38 ATP. Importantly, within this reaction, the production of acetyl-CoA is an important step because this is the backbone for lipogenesis and producing triglycerides. The glycogen synthesis in the liver is highly influenced by the balance of insulin and glucagon. Insulin will increase the activity of glycogen synthetase, while glucagon will increase the activity of glycogen phosphorylase, which will convert that glycogen back into glucose 6-phosphate, and the liver, being unique, has an enzyme called glucose 6-phosphatase, which can convert that back into glucose, releasing it back into the bloodstream. Then, looking at the liver's role with lipid metabolism, there's two main roles here. First, the synthesis of fatty acids converted into triglycerides and VLDLs, and then the second being the partial oxidation of fatty acids to ketone bodies. With regards to both of these roles, acetyl-CoA is central to lipid metabolism. You don't have to know these processes in detail, but a brief overview of how ketones are generated is generally important to know. Ketones are commonly produced in starvation by acetyl-CoA, which is generated through beta oxidation. Beta oxidation is the process of large-chain fatty acids being released from adipocytes, transported to the liver, where they're degraded into acetyl-CoA, and from here on in, there can be lots of different pathways that acetyl-CoA can go. It can be fed back into the citric acid cycle for energy, it can be reconverted back into triglycerides, it can be made into phospholipids, whether that's going into the cell membrane, or it can be made into ketone bodies. To make ketones specifically, you just need 2-acetyl-CoA to be converted by an enzyme called HMG-CoA synthase to produce the three ketones we know of: acetoacetate, acetone, and beta-hydroxybutyrate. These provide an ongoing source of energy, but I'm not going to go into this further because this covers another topic of fasting and nutrition, which we're not going to look at today. Then, with the protein metabolism function of the liver, this is as simple as understanding that protein catabolism can occur in the liver itself via one of three ways. They can either be transamination, deamination, and decarboxylation, and that's really as much as I knew for the broad overview. So this just broadly covers 1 out of the 8 functions of the liver, being metabolism. The second function we'll look at is excretion. And with regards to excretion, there are two important things that the liver is excreting. The first being urea, and the second being bile. With regards to urea, urea is made from ammonia in the liver via the urea cycle and excreted technically by the kidney. Urea itself is the nitrogenous end product of ammonia, and if you don't convert that ammonia into urea, ammonia can build up, and too much ammonia is toxic, and that's what happens in liver failure patients and why we end up giving them lactulose to bring down their ammonia levels. The important thing to remember about the urea cycle, because you won't remember all the steps, is that it's a cycle that requires energy. So if the liver is compromised, this cycle, which uses 3 ATP every time it goes through, will end up being neglected, and that's the reason when you get liver disease, over time, you'll slowly end up getting the buildup of ammonia. Then when it comes to bile excretion, bile is unique in the liver because it is both produced by the liver and excreted by the liver. The liver essentially acts as a large exocrine gland, producing roughly 1 liter of bile a day, which is then passed to the gallbladder, where it gets concentrated to roughly 1/5 of its volume. The 5 main contents of bile include bilirubin, phospholipids, IgA, bile salts, and cholesterol, and all of these are in there for a specific reason. The IgA is in there because the bile will be released into the gut and gives a form of immunity. The bile salts are in there because they function to emulsify the dietary fat, and this is essential for the absorption of fat-soluble vitamins like A, D, E, and K. Then moving on, the third function is storage. Here, we've already said that the liver can store around about 100 grams of glycogen, but it also stores vitamins, specifically the fat-soluble ones we've just talked about, metals such as iron and copper, and triglycerides. And this is always an easy point to remember. The next function is synthesis, and here the liver is having a huge role in the synthesis of things like plasma proteins, bile, coagulation factors, endocrine functions, and lymph. With regards to plasma proteins produced in the liver produces all plasma proteins except for immunoglobulins. Albumin is synthesized here at roughly 100 to 300 milligrams a kilogram of body weight per day, and this has a half-life of roughly 20 days and is regulated by the nutritional status of the person, the endocrine balance, and the oncotic pressure. You have transport proteins like lipoproteins, transferrin, and ceruloplasmin being produced here. You have hematological proteins like haptoglobin, antithrombin 3, fibrinogen being produced here. Immune proteins like the complement system proteins, your CRP being produced in the liver. Coagulation factors, pretty much all of them being produced in the liver at high quantities except for factor 8, factor 3, and von Willebrand factor. And you also have the anticoagulant proteins, proteins C and S, being produced by the liver itself. Finally, the liver also produces 25% of lymph fluid within the body. So synthesis is a major role of the liver. Following on, the next function is immunological, and I realized here I stuffed up the order of my missed HH by mixing up the I and the E. With regards to the immunological functions, we've talked about the Kupffer cells at the start, which are the macrophages of the liver, and this has a role in innate immunity, but also within the liver, we've mentioned the production of complement system, which is another part of innate immunity, and then the role in adaptive immunity is the antigen presenting capabilities of the Kupffer cells to the B and the T cells. Apart from the cells themselves, the other immunological function of the liver is because it receives that high amount of portal blood flow first from the gut, it has a major role in filtering that blood, in making sure it's free of any bacteria, drugs, and poisons. And this leads on to the next function of the liver, which is detoxification. We spoke about this when we talked about general pharmacological principles. With regards to detoxification, this can be both endogenous and exogenous compounds. Commonly, when we talk about exogenous compounds, we're talking about our phase 1 and phase 2 reactions, where remember, our phase 1 reaction's main role was to inactivate drugs, and this can either occur by oxidation, reduction, or hydrolysis, while our phase 2 reactions was to conjugate drugs by adding a polar group so that they could be easily excreted out, typically by the kidney. For these phase 2 type of reactions, the most common is glucuronidation, but you also have sulfation, acylation, and methylation. Key terms when it comes to this function of the liver is mentioning things like first pass metabolism because of the portal circulation, separating it from the systemic circulation, and then also the P450 system being in high concentration in the liver in that zone 3 classification of the acinus. Then our second last function is the hormonal function of the liver, and here we have the hormonal function of synthesis, activation, and degradation. With regards to synthesis, the liver produces things like EPO, angiotensinogen, and somatomedins. It activates things like conversion of T4 to T3, as well as having a role in the activation of vitamin D. And then with regards to degradation, it has a role in the metabolism of steroids itself. Finally, the last function, being the hematological function, also has an important role. Here there's a bit of an overlap, but I remember this more as the hemopoietic function of the liver itself. So these are things like platelet synthesis via the synthesis of thrombopoietin, the synthesis of EPO, if you haven't already mentioned it, and then the reservoir function of the liver itself. The liver can house a large amount of blood in a hypovolemic state, up to 400 to 500 mils of blood, and therefore that's an important function to know about clinically, because if you get a traumatic liver injury, you know that's going to be a big bleeding injury because of all that extra blood that's stored there as a blood reservoir. Now the list that I just made there isn't an all-exhaustive list, but it's supposed to be a broad overview of all the functions of the liver. There are certain things like acid-base physiology that the liver also has an important role to play in, but I think if you can remember those 8 functions, you have the template to answer both an SAQ or a Viva and be comfortable that you'll have enough points to at least get a pass mark. Moving on to the next learning objective, which I think personally is a bit more fun to look at, and it's actually 2 learning objectives combined into one, which are outline the determinants of liver blood flow and outline the portal circulation and its significance. When it comes to liver blood flow, this blood flow is really unique because of the portal system. The total blood flow to the liver is approximately 1.5 liters a minute, which equates to 25% of the cardiac output. And when you look at the anatomy of the blood flow going through the liver, it's very interesting. Starting off at the hepatic artery, which is a high pressure, high resistance system, this contributes 25% of the total hepatic blood flow, but importantly contributes 50% of the total oxygen supply to the liver. And these are important numbers to remember because people love to ask this in vivas. The saturation of this blood, because it's systemic and it's arterial, is roughly 98%. And because it's an arterial system, it has an arteriole which is pre-sinusoidal, which helps to control its pressure. The pressure pre-sinusoidal is roughly 35 millimeters of mercury, and post-sinusoidal it drops down to 2 millimeters of mercury. So this is a huge pressure drop that occurs, and it's why we refer to this as a low pressure microcirculatory system. Relating back to the important functions of the liver we just spoke about with our previous learning objective. Then we have the portal vein, which is a combination of the superior mesenteric vein and the splenic vein, and this has blood from the stomach, the pancreas, the spleen, and is a low resistance, low velocity system. Here, the portal vein contributes to 75% of the total blood flow, but importantly, only contributes the other 50% of the oxygen supply to the liver. And that's because the saturation of the portal vein is roughly around about 85%. So there's a large discrepancy between the percentage of total blood flow that's contributed by the hepatic artery being only 25% and the portal vein being 75%, but they both contribute 50% each of the oxygen supply to the liver. Also important to recognize with the portal vein, this vein does not have a valve, and I'll explain the significance of this in a second when we look at the determinants of liver blood flow. Then, as that blood goes into the sinusoids, aka the capillary network of the liver, because the pressure here is so low, roughly 2 millimeters of mercury, this is the area of the liver that can act as a reservoir. And I mentioned previously, it can hold roughly 500 ml of blood at any one point, but this can increase to upwards of 1 to 1.5 liters in certain situations like hypervolemia. Finally, the blood leaves the liver through the central veins, joining onto the hepatic veins, which have both the left and right hepatic vein that joins into the IVC. The hepatic vein, like the portal vein, does not have a valve, and this is important to know because it means that the pressure inside this vein can be affected by upstream factors like when we induce a patient and put them on IPPV. So understanding this anatomy first is really important as we now start to examine the determinants that alter liver blood flow. Like any organ, the goal of the blood flow is to match the supply to the demand, and the demand of the liver is quite high. Its O2 consumption is 50 mL of oxygen per minute, and this is equivalent to 20% of the total body oxygen, and it's also equivalent to other high oxygen consumption organs like the brain. Luckily enough for the liver, it's really good at O2 extraction, and it's very efficient because of the fact that the sinusoidal system is such a low pressure system. Here the extraction ratio is roughly 40%, but can increase even further to match the demand without the supply changing too much. So when we look specifically at the determinants of blood flow to this organ follow the principles of Ohm law like any other organ, but unique in the liver is that there's two different types of blood flow. There's the hepatic artery blood flow, which is determined by the mean arterial blood pressure minus the hepatic vein pressure divided by the hepatic vascular resistance, and then there's the portal venous blood flow, which is equal to the portal venous pressure minus the hepatic vein pressure divided by the hepatic vascular resistance. Now, because there are two equations here that determine hepatic blood flow, for me it was easier to think about the factors that affect hepatic blood flow in terms of the intrinsic regulation factors and the extrinsic regulation factors. In terms of intrinsic regulation factors, there's the common factor of autoregulation that we know about from examining other blood flows to other organs, and here in the liver, autoregulation only applies to the hepatic artery and not the portal vein. And that's because there's no arteriole sphincter within the portal vein because we already said that the portal vein is a valveless vein. With regards to the autoregulation zone, there isn't a graph that I could find that you have to memorize like when you look at autoregulation zones for the kidney or the brain, but what I've noted is that the autoregulation zone for the hepatic artery is not as wide as it is for the brain or the kidney. Autoregulation stops roughly below a systolic blood pressure of 80 millimeters of mercury. So because of this, there's a second important intrinsic factor which is very unique to the liver, which is known as the hepatic arterial buffer response. This is something that you really have to know because everyone loves to ask about this, and this response shows a relationship between the hepatic artery and the portal vein. It's sometimes referred to as a semi-reciprocal relationship, and that's because this response only occurs in the hepatic artery. What the hepatic arterial buffer response describes is that either a decrease in portal vein blood flow or an increase in portal vein blood flow changes the blood flow in the hepatic artery. For example, if there's a decrease in portal vein blood flow, the resistance within the hepatic artery decreases, increasing the hepatic artery blood flow by a factor of up to 20 to 100%. And if the portal vein blood flow increases, this causes the resistance within the hepatic artery to increase, decreasing the hepatic artery blood flow, which is seen in common pathological conditions like congestive cardiac failure. This response of the hepatic artery changing in response to the pressure within the portal vein is thought to be controlled mainly by the release of adenosine, which dilates the hepatic artery, increasing blood flow when portal vein flow is low. The reason why this response is sometimes referred to as a semi-reciprocal response is because a change in hepatic arterial blood flow does not change the flow within the portal vein. And because we reviewed the anatomy, we can kind of hypothesize why that would be. And my best estimate is because that portal vein is a valveless system while the hepatic artery has your arteriole, which can change its diameter and therefore alter flow and resistance. So these are the two intrinsic regulation factors you should know of. Autoregulation, which exists only in the hepatic artery and not the portal vein, and the hepatic arterial buffer response, which is a response in the hepatic artery blood flow in response to the portal vein blood flow, but not a reciprocal relationship. This then moves us on to look at the extrinsic factors that alter liver blood flow. And when you look at these, you can broadly categorize these into physiological and non-physiological factors. Within physiological factors, the unique things here are what happens with feeding. With feeding, you get an increase in portal vein blood flow, which will increase hepatic blood flow. And on the flip side, during exercise, you get increased splanchnic vasoconstriction, which will decrease hepatic blood flow. Respiration also has an effect on hepatic blood flow, with normal spontaneous respiration during inspiration increasing hepatic blood flow because of the effect of the negative intrathoracic pressure promoting venous outflow, therefore increasing the gradient of blood flow within the liver. But when you put the patient on mechanical ventilation with IPPV and adding in PEEP, this leads to a positive intrathoracic pressure, which leads to an increase in IVC pressures and a subsequent increase in hepatic venous pressures, which will therefore limit hepatic blood flow. CO2 and O2 also have an effect on hepatic blood flow, with the former having a bigger effect. When CO2 increases, you get an increase in hepatic blood flow due to portal vein dilation, and with hypocapnia, you get a decrease in hepatic blood flow, mainly due to increased resistance within the portal vein. In regards to hypoxia, this leads to an initial decrease in hepatic blood flow, but this decrease doesn't last long and returns to baseline within 20 minutes, probably due to the secondary effects of increasing cardiac output through our baroreceptors, sympathetic, and various cardiovascular responses. Now, when it comes to the non-physiological factors, I put in the neuroendocrine factors in here because these usually change out of the normal range when there's a pathological condition happening. The important thing to know with the neuroendocrine factors is that the hepatic artery and the portal vein have different receptors on them. With regards to catecholamines, the hepatic artery has both alpha, beta, as well as dopamine receptors, while the portal vein only has alpha and dopamine receptors. So this means when adrenaline is circulating in the system, this will lead to hepatic artery vasoconstriction through its alpha effect, but then dilation through its beta effect, while the portal vein will only have the alpha effect and therefore will only have a vasoconstriction effect. The dopamine receptors in general have very minimal effects within the hepatic artery and the portal vein. The other hormones that are important to know are angiotensin II, which as expected will decrease hepatic blood flow due to both hepatic artery and portal vein vasoconstriction, increasing hepatic vascular resistance, ADH, which will do the same by increasing hepatic vascular resistance and therefore decreasing hepatic blood flow, and then special substances like glucagon, which actually vasodilate, decrease the hepatic vascular resistance and increase hepatic blood flow, and vasoactive intestinal peptide, which also vasodilates the hepatic artery and increases hepatic blood flow. Now that's really all you need to know for this learning objective, because it's now been reworded to only focus on the determinants of liver blood flow. But back when I was sitting, this learning objective included discussing the changes that occur with anesthesia. And this is just a minor point to note, and it's very easy to remember. The key thing to take away is, no matter what type of anesthesia you provide, it'll likely lead to some degree of decrease in hepatic blood flow. So if you give a spinal or an epidural, this will lead to a decrease in hepatic blood flow based on the height of your block. A GA with IV induction agents such as propofol, etomidate, and thiopentone all have a dose-dependent decrease in hepatic blood flow, which correlates to how much decrease you get in cardiac output, and these agents will also stunt the hepatic arterial buffer response. And when it comes to inhalation agents, again this is a dose-dependent response based on the degree of decrease in cardiac output. An old school inhalation agent that we don't use anymore, being halothane, also specifically mentions that it loses the hepatic arterial buffer response, but interestingly enough, agents such as isoflurane, desflurane, sevoflurane reportedly still maintain this buffer mechanism. Which is why I think in my institution, we still use isoflurane when we do liver transplants. At least that's the pharmacological reason I can see behind it, or it may just be a historical thing. With this, we can now move on to our last learning objective for today, which is outline the laboratory assessment of liver function and hepatic failure. When it comes to the specific laboratory assessment of liver function, you have to understand that liver function and liver failure results in multisystemic effects. And at the core of this, it all relates back to understanding the functions of the liver, which was the first learning objective we covered today. I break down the important laboratory investigations into the tests that assess synthetic function, the tests that assess excretory function, the tests that assess the actual hepatic enzymes, and then finally any additional blood tests. With regard to synthetic function, we can look at the synthetic function of protein production in the liver, and the easiest protein to review is albumin. We know that albumin has a half-life of 20 days, so it's not a great protein to look at in acute liver failure, but it's a better marker to look at in chronic renal failure. On top of that, it gives you an assessment of the nutritional status of the patient as well. Then you have coagulation tests such as INR, and INR again will give you a little bit of information about the nutritional status of the patient if they have vitamin K deficiency, but it'll also tell you that synthetic function, particularly a rise in INR, because factor 7 is produced in the liver and is the chief factor in our extrinsic pathway. The other important thing with factor 7 is that it has a really short half-life of 4 to 6 hours. So if someone has acute renal failure, this will be the test that'll go off really quickly, and therefore the INR will be raised early because of that short half-life of factor 7 affecting the extrinsic pathway. Then the other synthetic test we can look at is a synthesis of hemoglobin and of platelets. Remembering that 10% of EPO is produced by the liver, as well as thrombopoietin that is also produced by the liver. And so these are easy synthetic markers to look at. When it comes to looking at the excretory function, here we can look at bilirubin, knowing that almost all serum bilirubin is unconjugated until it gets to the liver where it gets conjugated. Now with bilirubin, it's a bit more tricky because an increase in bilirubin can happen due to a variety of reasons. There are overall 5 basic reasons why total bilirubin can increase. 1, there's an increase in breakdown. 2, it's unable to be absorbed into the liver. 3, it's conjugated by the hepatocytes but unable to leave those hepatocytes. 4, there's a blockage in the excretory pathway in the liver, i.e. cholestasis. Or 5, there's a blockage somewhere along the bile system pathway. So while it's not a perfect test, it alerts you early that something might be wrong with the liver. Then you have the excretory function of ammonia, which gets transformed into urea by the urea cycle, and we can test ammonia separately as a direct measurement. The important thing to know when interpreting ammonia levels is that the level itself does not correlate with the degree of encephalopathy. Then, another excretory function, which we don't commonly think of but is an excretory function, is testing glucose. Remembering that the liver is the main glucostat in our body, if you start to see a patient with low BS cells with liver failure, this is a really bad sign that their liver failure is really advanced or they have acute fulminant liver failure. Then moving on, looking at the third category, which is the specific hepatic enzymes that we ask for in our LFTs when it comes to examining liver function. Here there are 4 specific tests, starting off with AST, which is a type of aminotransferase, in other words an enzyme present in hepatocytes that leaks out in liver damage. AST is aspartate aminotransferase, and it's mainly a mitochondrial enzyme. It increases with hepatic necrosis, but isn't fully specific for liver injury because it also increases in myocardial infarction, congestive cardiac failure, and with muscle injury. Then you have ALT, which is alanine aminotransferase. This is a cytosol enzyme which is way more specific to the liver. ALT rise only occurs in liver disease, and if you remember back in med school days, you used to look at the AST to ALT ratio, and if that ratio was above 2, it would suggest alcoholic liver disease. If the ratio was less than 1, it would suggest an intrinsic liver disease. So those are our 2 aminotransferases that we measure, but we also measure ALP, which is alkaline phosphatase, and this is mainly seen in the sinusoidal membranes, but also seen in the canicular membranes, and therefore is not unique to the liver, but also seen within the bone, the intestine, and the placenta. So it increases both in extrahepatic and intrahepatic cholestasis. But if you see an associated increase in ALT as well as ALP, you presume that it comes from the liver. Then finally, the 4th unique hepatic enzyme is GGT, aka gamma-glutamyl transpeptidase, which is a microsomal enzyme. It's present both in the liver as well as other tissues, and its activity is increased by alcohol and phenytoin. So if you see an AST and an ALT which is normal, but a raised GGT, this is a good indicator that someone's had recent alcohol intake. It doesn't necessarily mean that the person has liver disease. Then additionally, you also have lactate dehydrogenase, which isn't part of the hepatic enzymes, but is found in hepatocytes as well as other tissues, and an increase in this is a non-specific marker, and sometimes it's a non-specific marker when we're looking for things like cancer in patients, so this might be a clue to someone having a HCC. So those 3 categories are the big categories you have to remember when assessing the labs for liver function, but additionally, you have a whole host of additional tests that can give you way more information, and if you ever put down a hepatic screen in ICU, you know all the extra things that we add on that I commonly forget which make up your hepatic screen. So these are specific tests like looking at AFP, alpha-1 antitrypsin levels, serum ceruloplasmin levels for Wilson's disease, and then all your viral tests such as hepatitis, HIV, that you don't have to really remember for this exam, but are just important to know in the back of your brain from a clinical perspective. Also, from a clinical perspective, is thinking about the investigations in a multi-system way. So you can easily start from top down, i.e. CNS looking at ammonia levels, cardiovascularly looking at the hematocrit and the electrolyte levels, because with liver failure, you go into a hyperdynamic state of increased cardiac output but decreased SVR. From a respiratory perspective, you can do an ABG to look for hypoxemia because you get the sequelae of hepatopulmonary and portopulmonary disease secondary to liver failure. From a renal perspective, you can get hepatorenal disease due to splanchnic vasodilation, leading to an increase in the RAS system, and this can then lead to hyponatremia, hypokalemia, a decrease in GFR, an increase in urea, and an increase in creatinine, again suggesting severe disease. From a hematological and metabolic system point of view, you can check mineral levels and vitamin levels. Really, the host of tests that you can look at goes on, and you don't have to go down this rabbit hole. It's just a side note to know of because this learning objective is fairly non-specific. And with that, I think it segues us nicely to look at the past SAQs on this topic. And with regards to SAQs when it comes to the liver, my chief hint is to look at the cicm exam as well, because they take the liver a lot more seriously than we do, and there's a lot more SAQs that they get that are very high likelihood of being asked in our exam. So going through the SAQs, starting in order of the LOs we covered, which was firstly function, this was asked way back in 2015, and the question here was, outline the protective and regulatory functions of the liver. This had a 70% pass rate and had previously been asked 3 times before, and has also been asked in the cicm exam multiple times before. The best examiner report for this is in 2008, where it stated that this answer required a description of the liver as the interface between the gut and the body. When it came to the protective role, this was primarily related to the removal of bacteria, endotoxins, and protein denaturation. This is primarily undertaken by the Kupffer cells, which are in the hepatic sinusoids, and the action of these macrophages is an example of innate immunity. Following the activation, this leads to a series of events including phagocytosis, complement activation, and the recruitment of other cells. With regards to the regulatory roles, the primary role here of the liver is to be a glucostat, responding to both high and low blood glucose levels that are being presented to it by the portal circulation. Additionally, you get bonus marks for talking about the roles in toxin and drug modification, the production of acute phase proteins, the action as a blood reservoir, and the regulation of production of albumin in regards to regulating oncotic pressure. You could additionally also talk about bile regulation, bilirubin metabolism, hormone inactivation, and production of the coagulation and anticoagulation proteins. So really here, when it comes to making a model answer, you're trying to cover what we've gone through with our acronym of MIST-HH. And the key point within that is trying to relate everything back to the protective and regulatory functions of the liver without straying too off track. And for this, I think Ketamine Nightmares has some really nice subheadings. In regards to protective, they break it down into innate immunity, adaptive immunity, and detoxification. With regards to regulatory functions, you got macronutrient concentration, oncotic pressure, blood volume, red cell mass, coagulation status, extracellular volume, calcium hemostasis, and GIT absorption. There's also the cicm-rex model answer, which I think is a bit more streamlined, and here the subheadings are filtration, immune, storage of metabolic substrates, metabolic function alone, which would include things like carbohydrate, protein, fat hemostasis, and then your endocrine, biotransformation, and acid-base balance. And then finally, a subheading of synthetic function that would include bile production, protein synthesis, lymph synthesis, and EPO. So for this question, my tip is just to pick one method in which you're going to cover the most amount of points. And for me, like I said, it was going back to that MIST-HH. Following on from this, the next SAQ, which was asked way back in 2003, was describe the factors influencing hepatic blood flow. This had a 55% pass rate, and I'm surprised this question hasn't been asked again, but don't be fooled, this topic is an absolute favorite when it comes to Viva time. In the examiner report here, they've specifically stated that candidates are expected to provide anatomical information stating that hepatic blood flow has a dual blood supply, with the hepatic artery providing that 25% we spoke about and the portal vein providing the rest 75%. From here, the examiner report breaks down the factors you could talk about into the equation hepatic arterial blood flow is equal to mean arterial blood pressure minus hepatic venous pressure divided by hepatic vascular resistance, and portal venous flow is equal to portal venous pressure minus hepatic venous pressure divided by hepatic vascular resistance. The interesting point in this examiner report is that at the bottom it states, however, a number of candidates answered this question only from first principles, discussing the Hagen-Purcell equation in some detail without making specific reference to hepatic blood flow. That's why it's important to understand the anatomy we went through, because here you have that dual blood supply, and with that comes unique factors for the portal circulation versus the hepatic artery, specifically when it comes to things like physiological factors which we discussed, such as exercise and eating, which will have differing impacts on the portal venous flow. So for my model answer for this question, I would just break it down into those simple anatomical facts at the beginning of the differences between the hepatic and portal vein flow, and then link in the regulation factors using the two equations for hepatic arterial flow and portal venous flow. This would then lead into my regulation factors being those that are intrinsic and those that are extrinsic, which are further subdivided into physiological and then non-physiological. Within the intrinsic, you have to mention autoregulation, which only happens in the hepatic artery, and then the hepatic arterial buffer response, which is a semi-reciprocal relationship. Within the extrinsic factors, you have to mention the changes with feeding, exercise, respiration, and that can then link into the non-physiological factors, which is where I put the neuroendocrine stuff, such as the importance of your alpha, beta, and dopamine receptors, and your circulating catecholamines, the effects of angiotensin 2, ADH, and then the liver-specific hormones like glucagon and vasoactive intestinal peptide. For additional marks here, I would really want to hammer in the point that I know the anatomy of the hepatic blood flow, particularly that the portal vein and the hepatic vein are valveless veins, and this means when you put someone on positive pressure ventilation or give them PEEP, you're changing the intrathoracic pressure, which will have a downstream effect of increasing the hepatic venous pressure and therefore decreasing hepatic blood flow. There is a really mean question that has been asked twice in the CICM exam because hepatic blood flow hasn't been asked as an SAQ for a long time, and this question was compare and contrast renal and hepatic blood flow and their regulation. This is a fair question to be asked because both of these systems have unique properties to them, with the hepatic blood flow having that dual circulation, while the renal blood flow has a specific tubular-glomerular feedback mechanism. It also has differing blood flow when you compare the cortex to the medulla, which has clinical significance. And these two organs are linked to each other because when one gets affected, the other will get affected, classically seen in patients developing hepatorenal syndrome. Then finally, our last SAQ for today, which was the most recent SAQ that was asked, and this was still asked back in 2017, but with a low pass rate of 46%, which was outline the clinical laboratory assessment of liver function. There's a variant of this question that was recently asked in the 2024 CICM exam, and that was outline how the measurement of the following can be used in the assessment of liver function, with 25 marks allocated to each, being albumin, prothrombin time, glucose, and ammonia. From our perspective, our examiner report stated that the crucial approach to this question is to explain the physiological basis of the laboratory test. A simple name of the test provides marks towards a pass, but to reach a pass score, a candidate had to demonstrate an understanding of the underlying physiology. An example was given of a good level of explanation when discussing coagulation disturbances. Many candidates mentioned INR, but only few went on to explain why it was the most sensitive test for coagulation in liver failure by relating it to the half-life of the factors it tests. So really here, my model answer would stick to the categorization we went through, which is breaking down the test into the synthetic function tests, the excretory function tests, the liver-specific function test, and then any extra tests. And a good example of how you relate the tests to the physiology is take for example serum protein production. Liver synthesizes nearly all plasma proteins except for IgGs, and a decrease in total proteins such as albumin, globulin, and fibrinogen suggest impaired synthetic function due to hepatocellular damage. However, it can also be non-specific due to other conditions such as malnutrition states. We use albumin as a good long-term marker because of the half-life of 20 days, and therefore it's a good marker for chronic liver dysfunction. Again, taking that approach with coagulation studies, the reason we use INR is like we stated, the liver produces majority of all clotting factors, including the vitamin K dependent clotting factors being 2, 7, 9, and 10. The reason why INR is chosen is because factor 7 has a short half-life, and if you want to remember it easily, 7 for 7 hours, which is roughly accurate. This tells you two things if this is off. 1, there can be impaired clotting factor synthesis, or 2, does this person have a vitamin K malabsorption or malnutrition due to cholestasis or any other causes. Then when we look at the excretory functions, ammonia is a great test because the liver converts the toxic ammonia into urea through the urea cycle, and because this is only done in the liver, a high ammonia but a low urea suggests hepatocellular damage because urea is excreted through the kidneys, so if urea levels are normal but ammonia levels are elevated, this is telling you that the kidney is working fine but the liver is not. You can apply these same principles to the specific liver tests such as ALT, AST, ALP and GGT, which can help you differentiate the pathological cause of liver failure, whether it's due to alcohol or other causes, or whether it's intrahepatic damage or extrahepatic damage. So we've covered a lot today, and like I said at the start, this is a really big topic because this is a really important organ that if it starts to fail, has significant multi-organ consequences. And I do think the cicm Rex website does a better job of covering the content on liver physiology because it's more of an ICU-y type of topic. Nevertheless, still important for us to know. And just like you guys are learning this, I learn something every day. And for me, it was coming back and remembering why we use things like isoflurane still when we're doing major liver surgery or liver transplant, because it maintains that hepatic arterial buffer response. So I hope you guys got something out of today, and best of luck with your studying, and I'll catch you guys next time on Count to 10.